For a conversation about finding meaning in the moment, please welcome Kate Bowler, author of Everything Happens for a Reason and Other Lies I've Loved, and Dr. Sunita Puri, author of That Good Night, Life in Medicine in the 11th Hour. Here to lead the conversation is journalist Jeanne Meserve.
A lot of exciting talk today about the science and technology around cancer. But of course, there's always a person at the center of a cancer diagnosis. And we're going to talk a little bit on this panel about how to keep that person front and center when we're talking about treatment, when we're talking about quality of life, when we're talking about quality of death. Thank you both for being here. Kate, you were diagnosed with stage 4 cancer in your mid-30s with a young child.
Yeah.
How are you doing now?
Yeah, it's been not my favorite last couple of years, but it's a different way of life. It's a scan-to-scan kind of life, where I go in and they check me and they say, "Thank you, immunotherapy, for being wonderful. Let's wait and see." And then we all high five, and I go home. Yeah.
You, in your book, were very critical of the medical care you received, particularly during diagnosis. In fact, there was one memorable quote where a doctor said to you, "The sooner you get used to the idea of dying, the better." Talk to us a little bit more about the physicians you dealt with.
Well, I think I was just a little thrown. I was just in a weird place because I'm a professor at Duke University, which is very conveniently attached to the hospital, basically. And I'm also a historian, so I know, it's just like science words that I mostly lightly did not understand at all. And so when I got the call that I had stage 4 cancer, I was in my office and I was wearing like a reasonably fancy blazer. And then I walked over to the hospital, and then all of a sudden you're in rough cotton, and you're looking at, like, I am in academia, so I understand feudalism, but like little pyramids of people, and I didn't know who was important, and so it was so weird for me to suddenly be surrounded by people who weren't telling me how I was. They were using outcome language, which is just probability math. And I really struggled to feel like we were on the same team. Like, well, wait, I was fancy like 1 second ago. Let's be colleagues.
Sunita, why is it that doctors aren't better at talking to their patients about these very serious issues around diagnosis in particular?
That's a great question, and it's something that I struggled with when I was in my medical training, and I come to medicine with the sensibility of a writer. And so what I noticed in my training was that saying things very simply, like you are very sick and there is a chance that you may be dying, that became sentences like your prognosis is poor. And I noticed that change in myself when I was in my training and really lamented it because my patients would look at me probably like you looked at your doctors and were like, "What the hell are you telling me? What does that mean for my life?" Yeah. And I was so focused on talking about disease and outcomes that I lost the ability to really talk to my patients as a fellow human being. And I think in medical training, we are so focused on diagnosis and treatment, and we are not as focused on how we explain those things.
So in medical training, how much time would palliative care get?
So there is no standardized curriculum around palliative care in American medical schools. So where I went to medical school, which is actually a leader in palliative care, my exposure was really because I chose to spend elective time on the rotation. And I think just to briefly explain what palliative care
that would be useful because people complain about the name.
Totally, all the time. So just by show of hands, how many of you have heard of palliative care? How many of you have been confused about what that means? Okay, so you're in the company of like my parents who are like, we think she's a doctor, but we don't really know because we don't know what palliative care is. What it is very simply is medical and psychosocial attention to the experience of suffering. And we think about suffering as having physical components, emotional and spiritual components, which is something I think you wrote really beautifully about in your book. And we attend to all of those domains of suffering no matter what stage of disease you have. So palliative care should be offered alongside cancer treatment at any stage, not just at the end of life.
Getting back to the training issue for just a minute, it isn't just, I gather, about the time spent on it. It's about the mindset of people in the medical profession who are all about fixing things, correct?
Yeah.
Absolutely. If you even look at a lot of our studies in medicine and the language of the studies, we are looking at things like survival benefit. And that really means that's decoupled from the idea of quality of life. And we're more concerned now with studies that look at quality of life and how people experience their lives with treatment and with disease. But very much, especially in the world of cancer, outcomes are really about length of time we give people and less about the quality of time we give people.
And it should be more about quality.
I think absolutely, and helping people figure out what quality means for them at every stage with an illness.
Yeah. I'm just thinking of like the person who told me, like who didn't mean to give me the talk. He was just accidentally in my room at the time when I had questions. And it was like 4 a.m. and I saw this sweet little 12-year-old come in with a really short coat, which I didn't know meant I'm not sure what's happening. And then I said, and finally no one was in the room. And so, you feel like you can be honest if maybe you're not sitting around your parents who you're scared for and your husband. And I said, sorry, because I'm Canadian, so it always starts with sorry. I was just like, sorry, no one has told me, I don't mean to put you in this position, but no one has told me how long I'm going to live. And I was just wondering if we could go over that. And also, I don't know what legions are, and they keep saying legions. And he's like, I haven't Googled it. Also, no one wants you to Google things. So
Dr. Google is my nemesis.
Oh, sorry. Oh no, great. Oh, yeah. So I just said. He said, "Well, those are tumors," and I was so embarrassed. I was like, "Oh, there are tumors everywhere." And I said, "Well, so based on the words you're using, like, how much time do you think I have?" And he said, "I can only answer that by way of describing the probability of outcomes for someone with your diagnosis." And I said, "Well, then just give me whatever that is." And he said, "Well, you have a 30 to 50% chance of survival." And I like immediately reached out and I grabbed his hand, and he was like so uncomfortable. And I said, "You'd better be holding my hand if you're going to say stuff like that."
But that actually brings up something else that came through in both of your work. It is partially about the language, but you both made it clear that touch was something that was really important in these situations.
Yeah.
And you found your doctor was uncomfortable with it. Again, a barrier. How do we break it down, Sunita?
And I think touch can be a little tricky sometimes depending on the nature of the conversation and whether you have a relationship with the person. I think that we can convey compassion in a lot of ways beyond touch. And sometimes that is sitting down.
Yeah.
Sometimes that's asking what someone might need.
Yeah.
I think for when I teach my medical students and my residents, I talk to them a lot about slowing down when you're talking rather than blazing through your sentences, because even if you don't touch someone, when you slow down and make the time, that conveys compassion in a huge way.
When my best friend was dying of cancer, she said to me, "I'm scared."
Yeah.
And that's the moment when I realized that my principal role as the person by her bedside was to listen.
Yep.
And is that too often something that's ignored by physicians and sometimes even family and the rest of your community, that listening aspect?
I think that listening, like we might think we're listening, and when I reflect back on my experiences and my training, I always prided myself on being a doctor who listened, but when I look back on it, I'm not sure that I really was, because I wasn't really reflecting back to the person speaking what I was hearing from them, because it was almost like I felt like my role was to keep talking and to keep reassuring them that I knew what I was doing, when in fact what they really needed was for me to be quiet and just let them talk about whatever was on their mind.
I think too, there's I didn't realize how quickly you start to play a part.
Yeah.
So I really wanted to play the part of good and faithful cancer patient. Like if there was good sick and bad sick, I was gonna be best sick. I was gonna learn all the things. I was gonna be super cheerful so everyone would give me care I needed. And I was auditioning for the part of someone who wanted to be saved. And it's hard too when your doctor's your age and he mentions that I have a kid too. And you're like, oh, great, here's a picture on my phone. If you care about me, then maybe you'll make that extra call, or you'll look more carefully at my scan, or you're so desperate to make sure that you've lined up all of the odds so that somehow you'll eke through. And I think it's part of the deep, pernicious belief we all have that we can somehow save ourselves.
Yep.
And that we're not allowed to need each other. And hopefully medical care is this process of interdependence where we learn to need somebody else, but it's so scary when you just want to say I'm really afraid right now, and have someone hold that space for you.
How do you define quality of life?
I don't know.
I think it is so dependent on what someone is going through. I recently had 2 patients, both with metastatic pancreatic cancer, and both similarly debilitated by their illness. And when I was talking to them about what they want for themselves now and with the time they might have, both of them told me very different things. One person told me, it doesn't matter to me if I'm bedbound, it doesn't matter to me if I'm on prolonged life support. If I can feel the touch of my grandkids and hear the voices of people I love, that to me is quality of life. The other patient, who was at similar age, similarly debilitated, said to me, if I can't be independent in these ways, then that to me is not really a life that I define as mine. And so when we actually help people get granular about what quality of life means and go back to language, we can match their medical plan to what they value.
So it requires a conversation. When does that conversation take place?
I think these conversations should start at the point of a diagnosis of a serious illness. And it again goes back to this idea that palliative care is really about guiding you through an experience, even if we can cure you. So if I'm seeing someone who's going through a bone marrow transplant, a young patient in her 20s, definitely someone where we're doing everything to fix her disease, but the process of going through a bone marrow transplant is extraordinarily taxing. And so what quality of life means to her at every point is an ongoing conversation, just as it is for somebody who is dying of pancreatic cancer. The earlier, the better.
Some people say, is there a risk, and Kate, I'd love to get your opinion on this, if you have the conversation too early, are you extinguishing hope?
Oh man, and agency is such a tricky thing. I think we're all trying to find that little, one in the midst of debilitating circumstances, you're just trying to find that tiny little place to stand where you still feel like yourself. And I think it's, I was immediately scared of being eclipsed by things I didn't choose. I didn't have cancer in my family. None of this matched up with the stories I had about who I am and how I know how to live. And so I felt really overwhelmed immediately about how I decide, how do we spend our time? How do we decide what's beautiful and meaningful? And in a way, you almost know right away who to love. The who gets really clear. I love my little velociraptor. He was an amazing velociraptor for Halloween this year. And he was also recently given an award at school for not biting, which I feel was a huge triumph for all of us. And I attended that ceremony. So like the who becomes really clear. Like I knew right away, like I love my husband. I felt so terrible for my poor parents. Like, but the what and the when is really tricky. So weirdly, like that was the moment where I decided cancer is mostly waiting rooms, as far as I can tell. So I just wrote. I just wrote and wrote and wrote and wrote. Not because I was trying to be shiny anymore. I just wanted to have something that I knew how to give and feel like I could still in some way be myself.
I want to remind the audience to give us your questions. I know you've been instructed on Slido, so send it in for us. I want to touch on faith because it's important to both of you. Kate, you're an expert on prosperity gospel. Explain to us, give us the Cliff Note version of exactly what that is.
Sure. Yeah, I ruined my 20s studying televangelists and the idea that good things always happen to good people. And so it's the idea if you have the right kind of faith, so then God will give you health and wealth and abundant happiness.
But God didn't give you health.
No, that.
So did it change your relationship with your faith?
I think the hardest part was, and this is true of people religious or not, when you're sick, everyone's like racing to the explanation. They want to figure out in the fastest amount of time what happened to you and not them. And so like maybe it was a lack of faith, or maybe because I have colon cancer, it was something I ate, or I did not receive the essential oil collection from someone's multi-level marketing cousin. It was really hard to suddenly become like a problem to be solved. And I had to sort of give up on lessons, spiritual lessons right away. Like I believe in meaning, I believe in God's love. I just don't believe in lessons anymore.
Sunita, you also talk a lot about faith. It almost struck me that your practice of medicine is a kind of ministry.
That's a beautiful way to put it. And I was very lucky to grow up in a home where spirituality was front and center. My mother is an anesthesiologist, and I would round with her in the hospital when I was probably that tall. And I just remember her praying with her patients before she would take them to surgery and when they were in the recovery room. And I kind of was taught that everything is temporary. And I come from a Hindu and a Sikh background, and this idea that my parents taught me that everything that is will one day not be, but who you actually are is bigger than the physical world. And I lost some of that in medicine. And when I went into palliative medicine, I really started to see that language of everything being temporary, including our suffering, became a touchstone for a lot of my conversations with patients. And really this idea that who we are is bigger than our disease. Our identities are much more than being a patient or even being a survivor. We're much more complex than that. And sometimes what we want for ourselves is not what the body can bear. And the spiritual decoupling of who someone is from the limits of the body and the will of nature, those are the turning points in some of my conversations with patients. And this is deeply spiritual stuff that I get from my parents. And I am immensely grateful for that, because that's a perspective that I need when I walk into the room to see someone 10 times a day who's in the throes of suffering. No one can explain. No one knows why it happened. Yeah. And I see the person and I see the disease in the body as separate. And I think that comes from the language of my spiritual traditions.
We have a question from the audience. Can you share the role of multidisciplinary team care to optimize quality of life of patients with cancer? Sunita, you actually have come up against some physicians who've made it more difficult for you, haven't you?
Yes. I mean, I think that, again, in our training, the role of palliation and this idea of accepting that everything is temporary, including our mortal bodies, that's not taught to us. So when you are asked to weigh in on the goals of care or quality of life of somebody, sometimes the greatest resistance comes from my physician colleagues. And I almost feel like I have to be the most careful with my words with my physician colleagues. I have to be very careful with my patients and families, but definitely very careful. Like I have to reassure them, I'm not here to put someone on hospice. I'm just here to talk about their pain. And I think that's where multidisciplinary care really comes into the picture, because sometimes it's my team social worker that a particular physician may feel more comfortable with rather than me. And I think the perspectives that a nurse, a social worker, a chaplain, and a doctor bring to the same patient are varied and unique, and we need that team. No one person can do this sort of work.
Another question, what would you rename palliative care so it doesn't terrify patients and they would be more willing to embrace it? I agree, this person adds that it's desperately needed at diagnosis. Thoughts from both of you? A better name for it?
I'm going to defend this point. I
All
like
right.
it. I think this is part of the American obsession with individualism and hyper-agency, that we can't use words that allow us to be limited. I think we are just temporarily invincible for a little bit when you're 40 or something, and then the rest of the time you know that maybe your parents are sick or you're caring for a dependent. Like, I think it's, I want you to be just very pro palliative care right now. Just like, get them.
So this is a question that I get a lot. And I remember I gave a talk to the Department of Surgery, and the chair of surgery interrupted my talk to ask about this very question. And I think something I've learned through my training is to step away from euphemism and just tell people the facts as they are. And I think if we rename palliative care, we're trying to get around, A, the name of our board exam. That's literally, if you look us up, you're going to see board certified in hospice and palliative medicine. And to call ourselves supportive care or something else, it kind of sidesteps the issue, which is that people don't know what we do as a field. And so when I train my colleagues or my students and residents, I say, the most important thing is how you explain your purpose and the role in their care. So when I meet someone, I say, I'm from the palliative medicine team, and it's totally okay if you don't know what that is. I'm going to tell you. Yeah. And then I just say what I do and what I'm there to do, which is really to preserve their quality of life through the management of symptoms and through talking about what's important to them. And no one's punched me in the face yet.
Yeah. So, please join me
that.
in thanking Kate and Sunita.
So